Hello friends, this is Sudharshan and in this episode we'll talk about CSOM complications. So we will see about the most important complications of CSOM. So first thing is mastoiditis, which is the inflammation and the infection of the mastoid cavity or the mastoid air cells. So this is mostly common in children, those who have a beta hemolytic streptococcal infection and those who have already on antibiotics. So the pathology in this case is if there is any kind of infection from the beta hemolytic streptococci which enters into the eustachian tube. So through the eustachian tube the infection is going into the middle ear, and the middle ear consists of the chamber has attic, adytus and antrum which is connected to mastoid air cells. These mastoid air cells are situated in the bony cortex. So whenever there is an infection that enters this part, that is the attic, adytus and adantrum, it will infect the mastoid air cells and block the pneumatization function of it, and along with that there is something called hyperemic decalcification, where there will be the inflammatory changes in the mastoid along with the destruction of the bony cortex that happens, and there will be continuous amount of pus that will be generated from the mastoid, or I can say there is an empyema of the mastoid, because of which the pus can coalesce to form an abscess, and it can break, and this abscess can pass through the digastric triangle via the sternocleidomastoid and infect the digastric triangle or the neck space, and this we call it as Bezold abscess. And also apart from that, since it infects the middle ear, there will be a retraction of the tympanic membrane and swollen middle ear mucosa will be seen. And when it comes to the clinical features, there will be excruciating ear pain with a mucopurulent discharge, and there will be swelling behind the mastoid. Along with that, we see infection symptoms like fever, headache and chills. There are some important signs here. So there will be a mastoid reservoir sign where continuous amount of mucopurulent discharge will come out of mastoid, and there will be an area of swelling and excruciating pain. The hearing loss can be conductive or sensorineural. Mostly conductive. If it reaches inner ear, it will be sensorineural. Then apart from that, there will be tympanic membrane perforation as we see in the chronic suppurative otitis media, and as we see in the ASOM, we can have a nipple-like protrusion or a yellow spot on the tympanic membrane, as I told before, from where continuous pus discharge is happening from that. Apart from that, the sagging of the posterior superior meatal wall also can be seen. And when it comes to the diagnosis, there will be CBC showing elevated ESR, CRP and WBC, evidence of infection, X-ray mastoid and CT temporal, along with that culture sensitivity and antibiotics. And also if we examine the neck, cervical lymphadenopathy along with pre-auricular lymphadenopathy can be seen. And when it comes to the treatment, the medical management will be to give adequate antibiotics and analgesics and supportive care with antipyretics, steroids, reassurance, bed rest and IV fluids. And apart from that, to drain out the pus, myringotomy and mastoidectomy can be done, mostly cortical in this case, where actually what we do in this procedure is to cut the sternocleidomastoid fibers and along with that remove the bony cortex which has been infected. And in this case we use the endoral, endomeatal or a postoral approach. And when it comes to the complications of mastoiditis, it can lead to also petrositis and labyrinthitis, which we'll be discussing next, and intracranial complications as well. And also facial palsy, because inside the ear we have the facial recess where the chorda tympani and the facial nerve is present. So that is why facial palsy can happen. If it goes into inner ear, we can have eighth nerve palsy, where the eighth nerve actually supplies the vestibular system. And in this case, when it erodes the bony cortex, osteomyelitis and subperiosteal abscess will be seen. And that's the important pathological term here in this case. And I've told already about basalt abscess, where the pus is breaking out from the mastoid and going into the next spaces. And there are other abscesses which we see in this case, like the lung abscess when it goes into the external auditory canal, and from the mastoid if it goes into the suboccipital space where the triangle is present, that is the Citelli abscess. So we can see a swelling in the suboccipital region. And apart from that, it can lead to a retropharyngeal or a parapharyngeal abscess, which is very rare. And another condition associated with this is masked or latent mastoiditis. So this is where the symptoms of mastoiditis are not seen. So this is something like a asymptomatic condition of the mastoiditis, where inadequate amount of antibiotic treatment and observation was not done for the patient. So in this case, the patient will have regular symptoms of infection. Apart from that, as I've told before, the retraction of tympanic membrane, the perforation, sagging of posterior superior meatal wall, and we can see this in an X-ray mastoid or CT temporal. In this case, the surgery is same, that is cortical mastoidectomy with antibiotic course. Then petrositis is the next one, inflammation and infection of the petrous part of temporal bone. The pathology is very similar to mastoiditis. Here also we have the pneumatized air cells which is there. So any infection that will happen because of the beta hemolytic streptococci, it can affect the air cells in the mastoid. It can affect the air cells in the petrous part of the temporal bone in two tracts actually, posterior superior tract and the anterior inferior tract. So most importantly, this will cause a Grady-Negos syndrome, which is a triad of fifth nerve, sixth nerve palsy and ear discharge. So there will be an external rectus or a lateral rectus palsy. Sixth nerve, fifth nerve indicates retroorbital pain and ear discharge, as I've told before, mucopurulent discharge coming out of the ear and regular infection symptoms. Diagnosis will be through X-ray mastoid or CT temporal, and treatment will be cortical, radical or modified radical mastoidectomy, along with giving antibiotics and steroids. Then the next important complication is your otogenic brain abscess. So where there is a collection of pus in the brain because of a CSOM infection which is there in the ear. So that happens through a site called as Trotman's triangle which is present. And it will be associated with other intracranial abscesses like extradural, subdural abscess or a Pott's puffy tumor which we see in rhinosinusitis or a meningitis, etc. Bacteriology same. Common for the CSOM complications, beta hemolytic streptococci. Apart from that, Pseudomonas, E. coli, Proteus, Haemophilus influenza. Now there are 4 stages in this. The mnemonic is ILET. Invasion, localization, enlargement, termination. So invasion is where the pyogenic organism enters the brain. So constitutional symptoms will be present like fever, chills, headache, etc. And localization. So there will be areas or pus points will be formed in the brain. And then after that the area of the pus will start to spread and it will necrose the entire brain cells which are there. So mostly the cortical white matter is the site here. So there will be an inflammatory change with hyperemia and edema. Because of the invasion of the brain, the crucial functions will be affected. Like we can think, cerebral cortex is responsible for what? The control and coordination of movements, the vision, the forward vision, the thinking, execution, all these. The cerebrum and the cerebellum. Cerebellum, as we know very well, to maintain the balance, to do the flapping of the hands, that is your didecokinesia in that case. And if the cerebellum is affected, we can have ataxia, rhomboxane positive, we can have nystagmus, etc. And yes, there will be ICP symptoms along with papilledema. So, and we know very well, papilledema occurs because when the ICP increases. So generally there will be fever, headache, and there will be intense headache in the morning, especially with the sixth nerve palsy, especially. Yes, so the regional functions of the cerebrum, cerebellum, medulla, and pons. When it comes to the pons, the respiration of the person can be affected. Person can go into acidosis and death also. Right, so these are the clinical features in general as the abscess spreads in the brain. Then termination, this is where the symptoms will resolve. Yes, but in this case we will see a fatal meningitis. So initially there is a latent abscess, then a manifest abscess, and after that the abscess spreads and causes infection. And when it comes to the diagnosis in this case, CT MRI of the brain can be done, lumbar puncture, that is the CSF, to detect the infection. Treatment, medical management, most common antibiotics, aminoglycosides, penicillins, third generation, cephalosporins, mostly otologic and neurosurgical approaches there. Here the involvement of ENT surgeon is not much, only to take out the mucopurulent discharge from the ear, and the neurosurgical approach where the intracranial surgeries will be done to drain out the abscess from there. And then antibiotics will be started, then there will be repeated evaluation using a CT or MRI. Then after that we have the next condition, lateral sinus thrombophlebitis, also called sigmoid sinus thrombosis. As the name suggests, it is the collection of the, so basically there is a clot that is in the sigmoid sinus, which is a branch of the cavernous sinus, because of which there is inflammation and irritation of the veins that will be there. And when there is a pyogenic organism that invades this vascular network, so around the cavernous sinus, there will be a spread of infection and abscess will be there. Along with the abscess, there will be damage to the vessel wall, there will be a thrombus, there will be an inflammatory change that happens in the vascular network of the brain. So that's the basic pathology. So first thing, there will be an perisinus abscess along the vascular network, and then there will be the obliteration of the vessel and the external brain structures like the cerebrum, cerebellum, and then after that the clot extends. So there will be a thromboembolism as such. And then clinical features, the most important, hectic picket fence fever. So intermittent or regular fevers will be seen. Then headache, then there will be progressive anemia and emaciation. So here that is because there is something called a clot that forms, as I had told. So that is mostly because of maybe the patient has a disseminated intravascular coagulation, also called consumption coagulopathy, where lot amount of the red cells or the blood cells will be formed to give the clot. Maybe that is why the anemia will be present. And emaciation may be because of the progressive destruction of the brain tissue and the vascular network because of the infection there. Now some of the important signs, we have the papilledema, ICP symptoms, then Greisinger's sign. Greisinger's sign is mastoid emissary vein edema positive. So these are the important clinical features. Diagnosis, CBC with culture sensitivity for antibiotics, then CSF examination, CT MRI can be done. And complications, it can lead into meningitis, subdural, extradural abscess, then there will be the bulbar palsy where last four cranial nerves can be affected. And treatment will be the medical management with antibiotics, mastoidectomy, anticoagulant therapy better not to give, it's very controversial. Supportive treatment can be done with blood transfusion because anemia is present, or ligation of the internal jugular vein can be there. And last but not the least, otitic hydrocephalus. Here the CSF pressure is normal. Why? Because there is only damage to arachnoid villi. So the flow of the CSF is affected. The amount of CSF is not affected. That's why I'm saying in otitic hydrocephalus, you have the CSF that is normal. So that is because of the CSOM again, the cause. So when it comes to the clinical features, ICP symptoms like headache, blurry vision, headache is worse in the morning, 6th nerve palsy, papilledema, causing blurring of vision. So we can do an ophthalmoscopy to observe the papilledema, where retinopathy changes like exudates, hemorrhages can be seen. And CSF pressure will be normal if we do a lumbar puncture. So treatment will be a neurosurgical approach to treat the infection, and also there will be steroids and antibiotics which can be done. So as I've told already, that neurosurgeon approach is more compared to a ENT surgeon. So that's all. So thank you so much. We will see in the next lesson.